Okay, so again, thank you everyone for coming today. We have our special guest today, one of our alumni, Dr. Marcos Flores. He's a PGY1, a neurology resident at the University of Tennessee Graduate School of Medicine, Knoxville. And he graduated from UMHS last year. Thanks for coming, Marcos.
Hi everyone.
So today I'll be discussing stroke from non-thrombotic emboli. It's based off a patient that we recently got in our hospital and kind of went around the subject of strokes coming from something other than a clot. So today we'll just be talking about the different types of non-thrombotic emboli. I know there's other ones that are it's like one or two people have ever experienced them. So it's more of like the more common ones, even though this is a rare presentation in general. We'll also be describing clinical presentations and how they vary depending on the type and risk factors that are associated with them. And then as general principles for management with the various non-thrombotic emboli, because it is a bit different than thrombotic emboli. So we have our patient. He was a 64-year-old male. He came into the hospital. He was found at home by his wife. Him and his wife were out in the barn doing some chores and whatnot. And she left him for 5 minutes. He sat on a bucket and then he fell over. Um, when EMS brought him in to the ED, he had dysarthria. He had left-sided facial droop, left and upper lower extremity weakness on both sides on that side. He had no loss of consciousness, no tremors, no vision changes or incontinence during that period. He was on anticoagulation. He just had a past medical history of hypertension, hyperlipidemia. He had an aneurysm that was found a decade later that they had been following in the neuro clinic that they weren't concerned about. And he had a prior episode of atrial flutter that he had ablated. And to his knowledge, had no episodes since then. So with the presentation of his motor and facial droop and everything, can anyone tell me what side of the brain or like what territory this would be, you would think from presentation? If it helps, I think of like the ACA left and right, MCA left and right, and then PCA left and right. If that helps anyone.
That is a good way to think about it. So, as a very brief review, well, BCA, whether it's posterior circulation, we're gonna have like the dizziness usually. We're gonna have that is kind of the main problem, like vertigo. And anterior, we're gonna have a little bit of more like visual problems. The MCA is a big territory, so
Yeah,
whenever we're seeing like difficulty talking, using one part of your body, like the lower end of the body, even your face too, we're thinking more of MCA. So in this case, could be more MCA than other thing.
exactly. Um, yeah, and so I was learning this too as I've been on this rotation is like the stroke summary. This is the important things that the neuro residents are interested in. Last known well, we had brought the patient into the ED by 1730 or 1725. So he was within that window of if you're thinking about TXA or anything like that. His NIH scale is something that we use to kind of say how bad this stroke is if we're presuming it is a stroke. And because he had the upper and lower extremity weakness, the facial droop, and the dysarthria, he was given a 12 for all those factors. Um, he had some imaging, and so that's why the aspect score couldn't be obtained. He had a pre-morbid MRS of 0. His BP was a bit high at 174/91, but his glucose was 128. So we don't think it was like a low blood sugar issue or something like that.
So
And
just
that's why, yeah,
I'm sorry to interrupt. Just staying in this slide, last well known it was 1650, but when he arrived,
1720.
1720. So it
Yeah,
was less than an hour. So can
yeah.
anyone tell me what is the window that we're thinking for TPA or TNK. We use TNK now.
I think based on what last I have through my rotation was 3.5 to 4 hours.
Yeah. Usually it's 4.5
4.5.
hours, and now there has been studies that we're trying to extend that period for a certain amount of like a certain population to even 24 hours, but for now it's 4.5. So that is very important. That is one of the things that we ask when we have a cold stroke is the last known well. Usually we don't the EMS is gonna tell you another number. So usually if you're in the ED department, we don't get based on what EMS tells us. We try to call and talk to family or patients that have or people that have seen the patient and can tell us ain't exactly loves not well. The other thing with NIH numbers is that lower NIH numbers doesn't mean that it's less doesn't mean like it's less severe or less like it's severe for the patient. What it means is the probability of them recovering. So an NIH scale of 1 to 3, it can be a very good prognosis, but it can be a person with NIH 0 could be a candidate for TNK because if they play guitar or whatever and they have hand weakness, the NIH scale will not get you're not gonna put a number for hand numbness. It will be arm, it will not be hand. So in those cases, it's weird, but those cases we have seen those cases with NIH 0 and we do TNK. So keep that
Yeah.
in mind.
And yeah, when I was learning too, I didn't know about the pre-morbid MRS score, and because he was completely independent prior to this, that's why he got a score of 0. It's kind of based on like what their activity level was at home. So if he had his wife at home, but he didn't depend on her for like making meals or activities of daily living. Had he been in an assisted living place or something like that, the score increases to my understanding. Is that correct, Marcos?
Yes.
Um, And the reason why we mentioned the incontinence and everything too prior was like maybe there was a seizure that was happening or something like that. So that's why that was included. So does anyone want to take a crack at this imaging? You can say as little or as much as you want about it. We'll start from the left and move our way to the right.
We can start by talking about if it is a CT scan or MRI.
It
What
looks
it
like
is.
a non-contrast
Yeah,
CT.
yeah,
Yep.
absolutely.
So why do we do CT scan and like initially instead of MRI? Does anyone knows?
Is it a time factor, I'm guessing, for MRI being so much longer?
Yeah, that's right. That's one of the factors. So CT scan will be very quick. And usually if we see changes in CT scan, we're not treating that. If it is a ischemic stroke and we're seeing changes already in CT scan, we don't treat it. So in this case, what you guys can see, anyone tell me?
It
So
looks like
there's
there's
a,
a
yeah,
fluid.
tell
Oh,
me.
sorry, Marcos.
No, no, go ahead, go ahead.
It looks like there's like a fluid density on the right-hand side of the patient, left-hand side of the image.
Yeah.
Mm-hmm.
Um, and you can't see oh my gosh, I'm losing my train of thought here. The ventricle. You can't see
The
the
Yeah.
venture.
ventricle.
Yeah.
It's been a
Yeah.
minute for neuro guys.
Great point. So that ventricle is compressed there, and we're seeing, like you said, like a fluid is darker. You can compare it with well, initially with let's start with CT scan, you're gonna see dark it will be the darkest will be air, then it will be fluid like water, and then you're gonna have it in between, and then the brightest will be metal, like a chest X-ray, and you're gonna have bone density, and then we have a darker area that it's not as dark as the CSF, So it could be their water density, like you said, and then we see a white spot there.
Yeah, so this mass was the first time he'd ever been seen on imaging because, like I said earlier, he was in the neuro clinic like annually for an aneurysm that they were following. So this was a incidental finding during this time, and then it's hard to make out, but because I'm aware of it, you can see kind of a tail, and so this kind of gives you a clue as to what this mass most likely is in the brain tumor realm. And does anyone know what type of malignancy or tumor in the brain has like a tail that's connected to the dura?
Meningioma.
Yeah, exactly. Yeah. And so that was kind of, they were talking about, this also brought up a thing that I I don't know if I just missed it, but like different types of edema too that we experienced too. So this is likely a vasogenic. It's the most common type of edema, but it's from like the vessels being broken or and bleeding through and everything. You can have cryptogenic, which is more of like the small cell pumps are not functioning properly, to my understanding. You can have an osmotic edema, which is like there's like that fluid protein imbalance. And then there was a fourth one an interstitial or something like that. With Marcos, if you want to explain on those two.
So usually to keep it simple, we divide the edema in uh, cytotoxic or vasogenic. So cytotoxic is it will be inside the cell, like like cell,
Yeah.
and then vasogenic will be breaking that blood-brain barrier, and it's gonna spread. So anything that affects the blood-brain barrier will be vasogenic, like in this case. And the thing is that the one vasogenic, since doesn't respect the blood-brain barrier, you're gonna not gonna see a difference between what white matter and gray matter. With the cytotoxic, since it's inside the cell, you can see the difference. It will respect that boundary.
Interesting. Okay. Thank you. Is there anything else you wanted to comment about this image, Marcos?
No.
No. Okay.
One thing is that whenever we see CT scan, we also see at the eyes. You can see there in the right side, which is the left side, you're gonna see the eye over there. So that means that the person or the patient is a little bit twisted.
Yeah.
We use that to compare the both sides. So
Images. Okay. Um, and then this one is a little bit more specific and like higher training, but this is the MCA, and we're going into the M1 segment. It's like the first segment that's there, so it's blocking all the other segments of this vessel. So this is an early occlusion, which can be more devastating. So that, from my understanding, because everything else is being blocked off. And then this just was noted. This is in the carotid. This is a stable plaque, but they just wanted it to like have a full picture of the patient, but they don't believe that this plaque had anything to do with why this patient was experiencing these stroke-like symptoms at the stroke, because there was clear arterial blood flow going up to the brain. This was just a closer one. You can kind of appreciate that root a little bit better as well right there. And so from all this imaging and everything, we can assume that this patient is having an acute ischemic stroke of the right middle cerebral artery at the M1 segment. And it was found that this patient was an AFib with RVR at the time of him coming into the hospital. So we think it was due to possible episodes of AFib or hypercoagulable state, knowing now that he has that tumor. Other differential diagnoses was just like the brain malignancy causing these symptoms as well. He was also having tremors when he came into the hospital that he wasn't having at home, so they just added a seizure to the differential. It's fair to add sepsis or infectious etiology also contributing to it, and then very low on the differential was like a new onset neurological disorder, but just something to keep in the back of your mind as well. So for the plan for this patient, he received no tenecteplase because of the intracranial tumor. Especially there is a paper that was released in 23 talking about different types of brain malignancy and their susceptibility to bleeding if you give TNK, and in the pituitary region specifically has the highest incidence of bleeding if you give tenecteplase. And so because this patient's tumor was so close to that area, they didn't want to cause more bleeding. So they held off. They continued aspirin monotherapy. He was already on aspirin at home. He was given hypertonic saline 2% for the edema that he was experiencing and the mass effect it was causing. They had repeat imaging ordered, and it was showing evolving infarct and increasing swelling and a subfalcine herniation, so developing. So this person underwent urgent DSA, which is a image. It's a really cool image that I've been able to get to see this last month. It creates you can almost get like a 3D rendering of the vessels essentially and understand better what's going on. And then during it, they did mechanical thrombectomy. So that brought up all these topics of the non-thrombotic embolic stroke etiologies. We'll be talking about tumor emboli, septic emboli, merantic or non-bacterial thrombotic endocarditis, fat emboli, cholesterol emboli, and then amniotic fluid emboli. So starting with tumor. The tumor emboli can cause cerebral infarction through several mechanisms. Through direct embolization, so fragments of the solid tumor can travel and go into arterial circulation in the brain. It can also travel, if it's on the right side, it can go through a PFO or a VSD, some of those cardiac abnormalities, or during a surgery even. And the other mechanism is secondary thrombosis. So this hypercoagulable state from the malignancy itself can cause fibrin and platelet adhesion to the malignancy, and then it embolizes. The most common malignancies that are associated with tumor emboli are cardiac myosomas, lung with invasion of the pulmonary vein, cardiac metastases, and then breast cancer as well. Some risk factors other than the type of malignancy a patient has is how advanced it is, how their platelets or like blood irregularities are going with like the chemo and the radiation they may be going through, and just the advancedness nature of the cancer itself. Specific chemotherapeutic agents and radiation therapy can also have that predisposition. And then if they also have tumor-related MBTE on top of everything else they're going through. These are the only gross images I could really find. It was kind of hard to find them, but you can see these don't look thrombotic. They look more of like what you'd expect like a malignancy maybe to look like. It shows like a high tumor cell count, not a lot of blood in it. They're very string-like and they're very friable, so they're really difficult, some of them to do a mechanical thrombectomy on because they just kind of fall apart as you're pulling them. They can also have pigmentation and necrosis as well. When you look at them microscopically, you'll see tumor cells, erythrocytes, fibrin, and platelets, depending. And then if they want to figure out if they don't know where a malignancy is, they can do immunostaining to determine the source of the tumor. This was another one I thought was interesting. This one was actually hard, but it was kind of friable too. It was from a cardiac myosoma that patient had. They extracted from the brain. It was like a larger vessel they extracted it from. Most documented cases, it's common for patients to experience a stroke as their first sign of malignancy, and typically is associated with a higher mortality risk rate too, because if it's an advanced stage of cancer, you're going to expect a higher mortality rate. Due to the composition of the emboli, like I was saying, it's typically resistant to standard TPA because that's attacking fibrin and everything. And so if the fibrin's not present, it's not going to really respond to it. Moving on to septic emboli. It's when an infected thrombus detaches from a primary infectious source and travels through the bloodstream to obstruct a distant vessel. The embolization can occur before clinical presentation in most cases, but occasionally it happens after we start antimicrobial therapy in a patient. They can make it not stable. Risk factors is a lot. It can be endocarditis, indwelling catheters, prosthetic devices, IV drug use, heart conditions like AFib, or congenital heart diseases. Certain types of bacterial infections are more prone, like Staph aureus, because of how rapidly staph grows and everything. Systemic embolization is most common in the left side. Just think about it anatomically, that makes a lot of sense. And the neurological complications other than stroke can include brain abscess, meningitis, encephalopathy, meningoencephalitis, cerebral hemorrhaging, and seizures, secondary to the abscess or infarction. This was the best gross specimen I could find as well, too. It does, you can tell there's not just like a thrombus in here. You can tell like there's other, like, it's the septic like piece that's left off. Pathophysiology, they believe it's due to a dual insult of ischemia from the vascular occlusion and superimposed infection that may lead to the abscess forming. Left-sided endocarditis more commonly produces cerebral emboli, so it leads to the ischemic stroke and the occlusion of the cerebral arteries from the dislodged vegetations. These two genes that are more expressed, it was interesting. They found that these are more common, upregulated when someone's having a septic embolic stroke, and these genes are expressed for specifically inflammation and can make everything kind of worse as they're undergoing all of like a stroke from a septic emboli. So they're having increased mortality risk because of this as well, compared to a non-infective embolic stroke. And then, sorry, histopathologically, you can see the fibrinoid necrosis. I'm not the greatest at reading histology, but there's some necrosis in the vessel walls. You can see some neutrophilic infiltration within and around the vessels, and then you'll see clusters of bacterial colonies also present in them. They can have red blood cells within bands of fibrin. It's most likely due to it forming around it freshly versus it all coming at the same time, like it freshly forming around it as it travels. The hallmark of management for these patients is antimicrobial therapy and treating the underlying infection, since it is so hard to retrieve those clots, and then source control too when indicated. Surgical intervention is only for like select cases. And then endovascular management of the acute ischemic stroke secondary to septic emboli remains case specific, and it doesn't have really any established guidelines.
Adding something regarding the source control, that is the second most important thing. You have to make sure that if they have lines, we remove them, because
Yeah.
I had a case of a patient that he didn't want to do any procedures. He wanted to continue hemodialysis. He had infective endocarditis. We gave him all the big guns with antibiotics. He had antibiotics for 2 weeks until he died because he didn't want us to remove the catheter. So source control is
That's
very
unfortunate.
important.
Yeah, that's so unfortunate. Yeah. Moving on to sterile endocarditis, there's so many names for it, but MBTE is the most common lead that I see. So sterile endocarditis, it's deposition of fibrin and platelets on cardiac valves due to endothelial damage and subsequent connective tissue being exposed to the circulating platelets. These vegetations are very friable and subject to embolization, so they're just subject to this. So patients are typically asymptomatic until complications occur, like embolization or valve dysfunction. That's what I've seen too. They're verrucous, I don't know if I'm saying it correctly, but those are like really big. You typically think of like staph, and then Libman sacs is it's from my understanding a little bit smaller, is that correct, Marcos?
Yes.
Yeah, okay. But yeah, and I just attached some histology slides. You can kind of see like this is the normal valve tissue, and then you can see the thrombus. There's just a lot on there. Risk factors include active cancer, specifically mucin-releasing adenocarcinomas, so like pancreatic, lung, ovarian, gastric, and breast. If they have a hypercoagulable state for any reason, so like antiphospholipid syndrome. If they have certain autoimmune disorders like SLE, if they're older, if they're experiencing systemic emboli, so like DVTs, PEs, and then if they have damaged heart valves again. There are several mechanisms that are thought to be at work for these. They include circulating immune complexes. They're made of antiphospholipids, and they react to that exposed tissue, and then the hypercoagulable state, and then carcinomatosis, so just like the systemic circulation of the malignancy. APLs may also contribute to valve damage through the direct immune reactions that they're having. So anticardiolipin antibodies directed against the negative charged phospholipids and endothelial cell membranes. That's what they believe is causing all that destruction and the growth of those emboli. There's no specific treatment. Management revolves around controlling the predisposing conditions that the patient has, and the patient being on antithrombotic therapy lifelong at this point. Surgical intervention is rarely indicated from what I could find.
This is very similar of having an atherosclerosis plaque even in the brain, and if it gets irritated or if it is disrupted, it can become a non-ischemic stroke just because it clots there. So
Right. Okay. Moving on to fat emboli. It occurs when fat microglobules are released from the bone marrow and fat stores during trauma or surgery, and they enter circulation through the venous sinusoids. An inflammatory response creates this prothrombotic state, and it results in platelet aggregation. So access to arterial circulation can reach the cerebral vasculature, causing ischemia, vasogenic edema, and cytotoxic edema as well. Risk factors include trauma involving a long bone or the pelvis, orthopedic surgery. So if they're having like a hip or like knee replacement, and then intramedullary nailing too. It's these like thicker nails. They can also disrupt it. Soft tissue trauma and burns. Liposuction actually can. It's a small chance, and then a fatty liver disease is also associated with it as well. The Gerd and Wilson criteria are what is used for fat emboli, because it is hard to clinically diagnose. It's hard to visualize. You can't there's no gross specimen you can really see, and then imaging can be difficult too. So if you have two of the major criteria, or if you have one major criteria and four minor criteria, you can have like a clinical suspicion of the patient having a fat emboli. Gross exam, the brain will have these small like petechial hemorrhages. You can see all these little hemorrhages everywhere. The thrombi will not be grossly visible because fat is kind of clear and stuff, so it's hard to visualize. And then histologically, you'll see round clear vacuoles within the small arteries and capillaries. And they use oil red or Sedan staining to help find lipid droplets. If it's only neurosigns that are present, it can be difficult to diagnose. The CT brain is often normal, but you can have this artery sign called hypodense artery sign. It indicates that there's a fat embolus versus a thrombotic source causing the stroke-like symptoms or stroke symptoms. And then the MRI acute shows acute changes, including scattered cytotoxic edema, star field pattern, but it's also nonspecific. Lesions tend to be bilateral in the deep gray matter and watershed zones. Petechial hemorrhages are common. The management is guided by supportive care for these patients. Cholesterol emboli. This photo is of really bad atherosclerotic disease and then aorta. I think it was like a proximal branch, sorry. But cholesterol emboli from atherosclerotic plaques from the aorta or the carotids, when they rupture, they release cholesterol crystals to the smaller arterial beds, and it results in inflammation and ischemia. The emboli themselves are not visible on gross exam, but on tissue you can see multiple small infarcts or petechial hemorrhages too. Risk factors include severe atherosclerosis. They can be iatrogenic from invasive vascular procedures. If a patient's older, if they're male, they have an extensive smoking history, if they're hypertensive, if they have diabetes, it can all increase the risk of these forming. And then anticoagulation and thrombolytics can also precipitate a plaque being released as well. Histologically, you can see these biconcave needle shape spaces within the lumen of small arteries. The vessels will react with an inflammatory response, so there's intimal fibrosis that will occur, and giant cells can surround the clefts as well. Ischemic changes are due to acute infarct, and they're more eosinophilic, versus old infarcts will have like gliosis, like that scarring and the macrophage infiltration. Risk factors, kind of talking about that too, is cardiac cath or surgery. I was saying like the invasive procedures. There can be carotid interventions, thrombolysis, anticoagulation, or spontaneously occur too. Management is also supportive and preventative as well. Statins may decrease the occurrence because they help those plaques solidify or like just stay so that they don't embolize and cause a stroke.
There is a cool procedure now with cardiology, interventional cardiology, that if they have a plaque that is very big, and if you're a candidate and you have a good posterior circulation and everything, they go there and they reverse the blood flow in that area. So instead of going up to your brain, it's gonna go down. The other side is gonna perfuse your brain. And during that period of time, it's like 5 minutes, they can take that plaque, that cholesterol plaque or atherosclerosis plaque, and all the plaques are gonna go down. If there's any residues, it's not gonna go up. So there is a cool surgery that they do it now. Instead of going here, they go here. They go down.
That is so interesting. Even like the devices that they've used in this, they'll have like balloons, stents, and then an umbrella catching everything too to prevent it, like those emboli going up too. It's just crazy. They can combine all three in one device, like to remove. It's just crazy what they can do with those small little catheters and stuff.
Yeah.
And then amniotic fluid emboli. So they're relatively uncommon, but it occurs in 8 in 100,000 deliveries. And if it does occur, it's often fatal. It's a mix of amniotic fluid, fetal cells, and other debris that enter the maternal venous circulation. And it typically results in cardiorespiratory failure and DIC. Risk factors include specific obstetric procedures like C-sections, vacuum extraction, forceps, use and induction of labor. The maternal age is increased as well. If there's placental issues like placental previa or abruption, and there's certain pregnancy conditions that also increase the risk factors, so preeclampsia, eclampsia, polyhydramnios, uterine rupture, and lax occurring. And then multiple gestations, multiparity, and abdominal trauma all increase your risk. On gross pathology, findings are due to the systemic response of hypoxemia, hypotension, and DIC. So the patient will have cerebral edema. There'll be diffuse ischemic damage from global hypoxic ischemic encephalopathy. And then in setting of DIC, you'll see petechiae or interparenchymal hemorrhages also present, possibly. Histologically, you can find fetal elements within the maternal circulation. So they have found fetal squamous cells, lanugo hair, fatty tissue, mucin, and fibrin thrombi, which is what this photo is showing. The cerebral infarction is due to the emboli crossing into the arterial circulation via PFL or ASD in all documented cases. From the documented cases that there are, the stroke symptoms were noticed 1 to 5 days after the initial presentation. So once the patients were stable enough to be extubated, that's when they started showing signs. So just some general considerations. A non-thrombotic cerebral embolism is relatively rare, and these emboli are varied physiologically. So there's no uniform approach to the management of all these things, as we've kind of discussed. And a diagnosis is also different with all these different cases. So treatment can be largely anecdotal based on the documented cases and small case series that are out there. So this was the MRI that was done later with our patient. You can see a much better, like that dural tail, and just that like the edema around the tissue and everything. The patient, they ended up figuring out they concluded rather it was a high-grade meningioma that was occurring in this patient, rapidly growing and whatnot.
So in that,
Uh,
going back to the other image, the dangerous part of that, or the dangerous thing that you can see, there is like compression. You can see how the shift of the midbrain, like the midbrain, yeah, the line is compressing, and like Alexis said, the ventricle you cannot see it, so that pressure is very dangerous because if you don't do
absolutely.
anything, it gets worse. It can herniate. And the other one, I believe the one in the middle, there is an MRI. Probably that is a diffusion scan
Yes.
showing restriction of the diffusion, DWI. So
Yeah.
whenever we see that, is there is that part of the brain is not receiving enough flow. That is one of the image that we do, or the windows that we checked. If the CT scan is negative, we do an MRI, and the DWI will show you restrictions, and we compare that with the another window which is 8 something. You compare if in the DWI is bright and the other one is dark, you can see that there is a stroke there that you can treat, or if you don't see any changes in CT, because you're gonna see changes in an MRI sooner than CT.
Right. Right. Absolutely. Yeah, and then like what you were alluding to too, he ended up having to undergo a hemicranie because of the shift, and so you can see that ventricle kind of coming back out, um, and it relieved a lot of that pressure that they couldn't control during his stay. So all that to say, he had worsening cerebral edema and encephalopathy. He underwent that hemicranie. He was in AFib with RVR throughout his stay. He ended up having bilateral DVTs. He was on Eliquis during this time. He was in the ICU. He was extubated a little over a week later, and then he went to step down almost a week later as well. Um, and his left side, he still hasn't been able to really get much use out of, and he's still having difficulty speaking. And so they're going to have long-term physical rehab for this patient due to the dependence of PT and OT with this patient. So we'll see in 6 to 12 months kind of where he's at and how he's kind of growing from this with all the PT and OT help and whatnot, seeing if what kind of motor abilities he's able to get back and whatnot. Um, so yeah, the final diagnosis, it was a large right frontal lobe tumor with a worsening vasogenic edema, a suspected high-grade meningioma. He had a right MCA occlusion, status post-mechanical thrombectomy due to AFib, and then he had worsening cerebral edema with encephalopathy. And these are thank you. Thank you so much, Marcos, for coming and um, all the things.
You're welcome. No problem. Does anyone have any questions at all? Well, thank you guys to inviting me. It was nice to see you guys again.
It's great seeing you too, Marcos. Thank you so much.
Yeah, whenever you guys